Okay, great. So let's go ahead and get started. First, before we jump into housekeeping, I want to make sure I say thank you to my comms team. Megan Pizzacki, Daniel Dean, and Brianna Kennedy are working behind the scenes to make sure that everything goes off today without a hitch. So thank you. Um, and let's go ahead and jump in. So welcome everyone to our webinar today, Staying Informed, Understanding Local Impacts of the Public Health Emergency Ending. The Vaccine Equity Cooperative is pleased to host this webinar in partnership with Health Leads. And this webinar is part of our ongoing work and commitment to support those of you working in communities and partnering with communities to fight the pandemic. I am Tanae Franklin, and I will serve as your webinar moderator today. Next slide. So today's webinar is available in Spanish. To listen to this presentation in Spanish, click the globe interpretation icon at the bottom of your Zoom screen and then select your language. This webinar also has a closed captioning option. To enable closed captioning, please click on the closed captioning icon at the bottom of the Zoom screen. I will give everyone a moment to find that if necessary. And then with regards to housekeeping, before we begin our conversation today, there are a few housekeeping items we'd like to review. Today's webinar is going to be recorded, and yes, it will be sent to everyone who's registered, along with any additional materials that are shared. Today's webinar will have time to answer as many of your questions as possible. You all submitted a lot of questions in advance, so we're going to draw from those as well. While you're here in the webinar today, please submit additional questions using the Zoom Q&A function button found at the bottom of your screen. And you can also use the Zoom chat feature to share comments and reactions to communicate with other attendees and panelists. And last but not least, at the end of the webinar, we're going to launch a poll, actually 3 polls, to better understand an evaluation survey to get feedback to see how today's webinar went. Okay, next slide, please. So today, we're going to talk a little bit deeper with our colleagues, Dr. Sammy Ariola and Dr. Gil Wright. Everyone deserves access to information. With the public health emergency ending, it's crucial that everyone has access to the information needed to keep themselves and their communities healthy and safe. We're in a place now where states are actively trying to deny access to information. In today's webinar, we're going to be uplifting and focusing on answering the question, how does the impact of the COVID-19 response, what is the impact in our local communities? And what can we do to make sure that we have the appropriate information with regards to food, housing, telehealth, Medicaid, and of course, access to vaccines and treatment. We're thrilled to have 2 experts today. Dr. Gil Wright, whom I have the pleasure of working closely with. He is the director of the health department at Metro Nashville Public Health Department here in Nashville, Tennessee. And I serve on the board, and that's how I work directly with Dr. Wright. With regards to Dr. Ariola is the Deputy Chief Administrative Officer, Health and Human Services and Education, Prince George County, Maryland. And I look forward, Dr. Ariola, for you at the appropriate time sharing additional information about the agencies that you're responsible for. Okay, next slide, please. So the COVID-19 public health emergency officially ends at the end of the day on May 11th, 2023. You probably saw that yesterday, President Biden did sign the documents to actually end the public health emergency. And if you're like me, it comes with mixed emotions. We also know that the federal administration has determined that the nation is in a better place in its COVID-19 response compared to 3 years ago, and that the nation can now transition away from the emergency phase. And this information is coming from the transition roadmap that the federal government has put out, HHS. We also know that the widest ranging initial impact will likely be higher costs for COVID tests, both at-home tests and those performed by clinicians. And that impacts people's ability to get timely COVID diagnosis, treatment, and prevent transmission. The most significant impact will come when the federal supplies of COVID-19 vaccines and treatments are depleted. So the timing of that is hard to call, but we know that these things are coming down the pike. The way that we were able to get through the pandemic as the Vaccine Equity Cooperative is by sharing information like we're doing today. And while we do have two experts here in the room with us, I also consider you all across the country are Vaccine Equity Cooperative participants as subject matter experts too. So I fully intend to walk away learning from this conversation today. Next slide. Next slide. Okay. So our webinar goals, make sure that you all have the necessary information to understand the immediate and most important public health emergency COVID response, understand what federal information has cascaded down to state and then on to local public health agencies, discuss equity-driven and community-centric long-term public health safety plans, and share potential roadblocks and upcoming opportunities to continue our COVID-19 response. And lastly, like we always do, like to share a little bit about the Vaccine Equity Cooperative, but this time we're going to talk about what comes next after the cooperative. That being said, I'd like to go ahead and jump in and turn our attention to our speakers. We're going to now hear from Dr. Sammy Ariola, who's the Deputy Chief Administrative Officer for Health and Human Services and Education for Prince George's County in Maryland. Dr. Ariola?
Thank you, Tede, and the rest of the team for inviting me to this great program. And good afternoon, everyone. Really happy to be part of this. Very happy to be with Dr. Wright, who we used to work together in Nashville just prior to the pandemic. And the pandemic COVID years, I spent as the Director of Health and Environment for Johnson County, Kansas. But the experiences that public health went through in the past 3 years, I think has revealed a lot. And then we get into the equity piece. But we have had years of underinvestment in public health. And the reason those are important is the impacts, the more pronounced adverse impacts are very related to social variables, economic variables, which basically mean that people that are poor, persons of color, are going to face the more difficult consequences of the impact. The second piece that's pretty obvious is what we say in public health, that health is profoundly local. But the capacity at the local level is not very big. And those capacities vary depending on which community you are in. Of course, there are other political considerations depending on which state you are in. And so all of those experiences, social variables, economic variables, political variables are some of the big things that we experience, in addition to the underinvestment in public health. One of the lines that I used while I was in Johnson County with the demands for us to distribute vaccines as quickly as we could is to highlight the fact that the resources just did not match the expectations of the public from local health department and state. It's like playing a basketball game without a bench and perhaps even three players rather than five, or investing in a Centra and expecting a Cadillac. And so all of those are very important so we understand the impact of the public health emergency at the federal level, because local capacity were quickly overwhelmed. It was very important for the federal government as well as the state government to step in to make sure that we protect the health of our residents across the country. And the public health emergency, as well as other declarations, really enabled the government to provide resources for testing for COVID, the virus that causes COVID-19, for treatments and for vaccines at no charge. And the second key part of that was because it allowed for enhancement of social safety net benefits. And I will get into some of those, again, to minimize the impact of the pandemic on residents, the rental assistance, utility assistance, housing payments that people received. All of those are very important. Even without COVID, to be clear, the CDC a few years ago conducted a study as part of the HI5, they call it health impact in 5 years. And one of the consequences that we see is that even payments, additional payments of 2,000, 3,000 going into households from an income credit made consequential, measurable impact in public health. So we know that if you are poor, your health is poor. So again, we have, and these impacts are felt typically in communities of color. And so the impact on housing, the impact of closures. We closed at the first week that I spent in Johnson County. I was with other leaders in the community, closing down restaurants and other places in the region, Kansas City region. And so those were very impactful. The other piece was the so-called essential workers, where even before the vaccines, people that were working at the restaurants, at the grocery stores, at the pharmacies, those are typically people on the low end of the socioeconomic scale, and typically a lot of them tend to tilt towards persons of color. So equity was a big piece. So this declaration was very, very impactful. Even before there was vaccine, especially during the vaccine, it became even more impactful. Now, I remember, the first set of vaccines that we got, and we were looking at the numbers. And one of the first things that I noticed is there was a lot of jostling for vaccine in Kansas, working with the state Department of Health. And we were getting very little supplies of vaccine, and then we were prioritizing who gets what first. First responders. Of course, people were jostling. A lot of first responders, fire, EMS, powerful people from utility companies were at the table. Well, guess what? It was pretty obvious in the first part was you didn't see a lot of communities of color at the table arguing for receiving the vaccine. And there are multiple layers to that statement. Part of what we learned in this pandemic is that we need to build better bridges, trusting relationships into the community. And that's why, we were going to communities that we had underinvested in for years and offering to even pay them money to get the vaccine. Of course, they were skeptical. So you didn't care about me before this, so why are you paying me money to get the vaccine? So there's got to be something in there for you. So again, all of this just to really talk about the initial inequities that we saw in the vaccine distribution. But I'll give credit to the federal government. I'll give credit. Last week, I was at a conversation with some of the CDC director and others with Kaiser Permanente. That's kind of talking about how do we get better moving forward, and some of the steps that they took to ensure access to vaccine at no cost to everyone was very important. Some of these resources that allows like qualification for for Medicaid. Those things, some people we know across the country, probably up to, I think I was checking the number, up to 15 million people out of the 81 that are current beneficiaries for Medicaid will probably lose that once the recertification, redesignation starts. And so we're already having those conversations. I mean, Maryland now, we're having those conversations with the Maryland Department of Health and health officers, which I'm still acting as the health officer here in Prince George's County. We're having those conversations to make sure that equity is at the forefront of this, that we do this in a way that minimizes the impact on people at the lower end of the socioeconomic status, and use equity to determine that. And so that's going to be done in a humane way. At the health department, we are already reaching out and educating the public on to get ready when this starts so that they can re-enroll and re-register. We are trying to devote resources to doing that, not just from the health department aspect of it, but also for social services, all of the other things, utility assistance, rental assistance, food, housing, all of those things that are going to impact a lot of people. There's a few, probably an estimated close to 400,000 persons will be impacted in the state of Maryland. And so the challenge for us is a lot of the gains that we made, a lot of the things that we already knew that were pretty clear during response to the pandemic, that access to housing, access to food, access to preventive health care, all of those things are very, very important. Look, we define health as not just the absence of infirmities or disease, but a state of complete physical, emotional, social well-being, mental well-being. And so if it's tough to be healthy if you don't have food to eat. It's tough to be healthy if you are not sure that you can pay for your accommodation. But I'll tell you, one of the things that's going on across the country, across municipalities, including ours here, is that local elected officials are rising up and they're trying to fill those gaps. I am seeing initiatives around rental assistance. I'm seeing initiatives around subsidizing people's income, certain amount that you just get a year. And across the country, we see that income stabilization projects, what they call them, and just by providing additional $500, $600 a month to people, people are able to pay for their housing. They're able to go look for a job. And so the argument that will make people lazy, data does not support that. It actually shows that people, when you do that, people get more, they have higher employment rate, people are healthier. And so again, we know these facts. You look at the United States, we spend $4 trillion a year on healthcare. That's about 20% of our GDP now, approaching that. And far more, almost double what the rest of the OECD countries spend. However, we are not the healthiest country. Some years we actually were dead last. And some years we're like 28 out of 32 OECD countries. So the difference is those countries spend more on these social amenities. They know that when people have access to 3 square meals, all of those things are very important. In terms of the public health emergency, because one of the at least questions that were sent ahead of time that I do want to touch on is the impact on access to vaccines and medications for COVID-19. How would that be impacted? To be clear, and I think the federal government's been saying that there are some other things, like if Medicare Part B, for example, will continue to cover some of this cost until the end of 2024 and perhaps more. And the idea is to move this, what has been a federal government subsidized response, to more of the local, the healthcare marketplace. So that becomes part of that. And the one thing that we know is that for vaccines that are recommended by ACIP, that those vaccines, most payers would you get them at no cost. And so, and again, I think one of the fundamental reasons is lack of allocation of funds by the Congress to continue the efforts. But we also know it's pretty tough based on the numbers that we are seeing to justify continuing this indefinitely. And so, again, the idea is just to make sure that, again, it's not just COVID. You've got flu, you've got other things going on. And so we are happy to continue to educate the public on, especially if you're high risk, on basic concepts. Wear a mask. And if you're sick, stay home. And all of those basic things, and get tested when you are. And of course, the pharmaceutical tools that are available to use them. And again, the challenges that we have is in communities like ours here, for example, access to healthcare resources is still a challenge. I was looking at some numbers recently. A lot of our residents have to go to other counties to seek even preventive health care. If you have high risk pregnancy here, you have to go to a different county to get to receive medical care. So it's not, the impact will not be the same across the country. And for communities of color, for equity reasons, the burden that has to be carried is much bigger than communities that have more adequate resources. And so the impact will not be uniform. Some will be more impacted than others. And so we have to continue to pay attention to those things. The last thing that I'll talk about, I don't know how much I'm doing on time, is just to consider the other parts. Some of the things that we face, actually two things. One is to understand that in the past 3 years, we have lost 50% of the public health workforce. So when people talk about how do you continue to educate the public, how do you continue to carry on public health? Look, public health is everything that we do before we need to seek healthcare. Now, while we have invested a lot of money in healthcare, we have not done the same thing for public health. It's actually really striking. As I was saying before, it's like paying for a Sentra and looking for the services of a Cadillac. It's really impactful to see how grossly underfunded public health has been. And even when APA funds came, okay, 2 out of the 4 top priorities were to boost public health infrastructure. That's not really what decision makers did. Even the recent public health infrastructure funds that comes in, the language there was give at least 40% to local public health departments. The states are withholding, they're taking that as gospel, and they're taking 60% of that and distributing 40% among several local jurisdictions. So the funding mechanism has to change to ultimately allow local public health department to do the work that they can. Now, again, since part of my job is to answer your question, the 50% is in the last 3 years, the pandemic. People were either fired, people were either forced out, like people, that happened to me too in Kansas, where I got a call from my legal department that they're coming to my house to come and protest in front of my house. So that happened to at least 3 colleagues nationally that we read in the news. And they feared for their family and they resigned. Others were fired. In Kansas, for example, the changes to health law was the decisions were taken away from experts. They were taken away from the Secretary of Health. They were taken away from local health officer and put in the hands of politicians. The argument is they want people that are elected to be the ones making the decisions. So at some point, even when we had a TB case in a classroom, it was impossible for the health officer to mandate exclusion or wearing of mask. Those decisions were left to the school board. So the impact of these things are going to be felt for years. And so we have that, those are true numbers. The Beaumont Foundation just did a study that's showing that local health department needs over 70,000 workers to get to the level to do the things that we need to do the right way. So that workforce is very important, and every department you see, they are really just right now struggling to keep up with the basics. And because of the pandemic, look at the explosion in mental health metrics that we see. Like my county executive here puts it, it's pretty tough. We found out in the pandemic that when we send these kids home, they came out mentally worse than they were before the pandemic. So there's got to be something in the home environment that's nurturing those things. So we've got a lot of work to do, and those funding, those resources, because we say health is profoundly local, we have to find a funding mechanism that funnels those money more to local health department than the state. I would say that the state and feds were very, very helpful during the pandemic. Local capacity was overwhelmed. We did all we could to open up testing centers, to open up vaccination centers. In that case, we used a lot of health systems early on, but it took the state coming in and funding and overseeing several other testing locations for us to meet the needs of the community. So the collaboration is important. Collaboration between public health and healthcare system is very important, but also resources. The last piece is the disinformation and the misinformation things that we saw. That was pretty tough. You see people that are saying things as if they are facts. You see, there's ivermectin. We spent weeks. Some doctors are still prescribing that. And so it's not just putting out the information, it's finding a way to overcome the threshold of this information, which is now so high. And so the noise is so high that the true information, to get it to people, will require a new way, a new approach to public health. And I don't believe that we currently have the resources to do that. So I don't know where my time is, but thanks for the opportunity to talk. I'll be looking forward to answering some of the questions.
Thank you, Dr. Ariola. Dr. Wright, would you like to chime in on the local impact of ending the federal public health emergency? I know I saw you sort of nodding throughout Dr. Ariola's remarks, so I would love to hear from your perspective what that's been like here in Nashville, Tennessee.
Yeah, Sammy, thanks for telling them everything. No, I think that Dr. Ariola did a good job of summarizing a lot of the things that have occurred locally as well as nationally. The one thing, the sad thing is that this pandemic really enabled us to see the disparity in care. I think public health has always known that there was a disparity in care, but this really made it very evident to a lot of people outside of public health. And so if there is any good thing from this pandemic, I think that it's at least drawn attention to those disparities. Now, if we can continue to get funding and things going forward, that's going to be the key. I think I'd like to set up Nashville's story just a little bit. We had a tornado 1 week before we had our first COVID case. Sammy was still here at that time. Then during the early COVID days, we had demonstrations, not wanting to wear masks, not wanting to do the mitigations. We live in a very red state and a blue city. So it was very, at times, oppositional. We had a Christmas Day bombing that first year downtown that put additional stress on all of our emergency people and such. And shortly thereafter, we started our first vaccinations. We were able to do one vaccination event where we did 10,000 people, but we on a daily basis, once we got vaccine availability, were able to do 1,000 new vaccines a day. And also, once we got up to the point where people were coming back for their second, we were also giving them boosters. So about 2,000 vaccines a day. We had problems with our legislature, as Dr. Ariel already discussed. They took away our ability to give public health orders. We were lucky enough that they did realize they shouldn't probably take it away for things like TB. They specifically named COVID only. Then we had monkeypox or mpox. And then finally, unfortunately, just about 2 weeks ago, we had a mass shooting at a school. We're ready to be done and moved on from this pandemic and hopefully all the things that have been associated with it. I think the thing that we got out of this very early was our hospitals came together. They worked very hard to set up testing centers. We were one of the first places in the state to be able to do testing. We provided testing throughout the event, throughout the pandemic, free of charge to our community. We were able to work with a historically Black college in Meharry Medical College, and they provided all of the staffing for over 108 weeks for testing and then ultimately vaccination at those sites additionally. We worked with a number of organizations, CBOs, medical groups here in town. And initially what we found when we were starting to just gather stuff and doing testing, we didn't have the capability in the system that the state uses to even capture primary language. So if we're calling somebody back with a test result that's positive, we don't know ahead of time that they speak Spanish or Arabic. So it just delayed that conversation. We've fairly quickly got the state to change their database so that we could add that. It was very important for us to have that. And then we would make sure that we had individuals that had that primary language and were able to talk through those things. Along with that, what we learned was it was very important to work with our community partners. And initially we had a lot of contacts. We worked with people, but as this pandemic has gone on, those have grown to be very trusting relationships. And I'm very hopeful that as time goes on and we move past the pandemic, we continue to leverage those working relationships, those partnerships to increase the healthcare quality that we're providing and the types that we're providing, making sure that we're providing them culturally appropriately, because that's one of the things we also learned. We started very early translating information from English to Arabic, Spanish, and several other languages. But to just change the words from one to the other didn't necessarily meet the population's needs. We needed to have our partners help us in making sure that we were delivering a message that was culturally appropriate so that they understood better why they should get vaccines, why they should mitigate, if they've been exposed. Along with that, we had an issue with food. Very early, we were providing food for those individuals that were unable to get food at home. Unfortunately, the group we were working with only had one kind of set of items that they were putting in, and it wasn't appropriate for, it contained pork, so it wasn't appropriate for Muslims. It wasn't appropriate for some other religions. It didn't contain rice and beans like a lot of our minority populations would be used to. So we worked hard to try and correct that. Unfortunately, I have to say that one didn't work as well as we'd liked. But we've learned a lot of things along the way. We're in the middle of a after action report and hope to have more information about all of these things that we did and their impact. And so that we have those things for the next pandemic. Although with the next pandemic, I expect to take my pandemic plan and have it. And probably the first day it'll go out the window because it's always different every time. And the situation is different. The population's different. Nashville continues to grow very quickly, and we're in the situation where we have concerns from a public health standpoint. We're going to price everybody out of the county that is these minorities. Our public health, our healthcare will look good, but we will price everybody out of the county, and that's a concern. All these things have kind of come up. I expect vaccine. As I said, we provided vaccine throughout this pandemic, and over the last 18 months, we've had strike teams. These are individual nurses and other staffing people that we're sending out on a regular basis, on daily, sometimes several places a day, where they're out in those underserved areas, giving vaccine testing and such. We expect to continue that even when the public health emergency is over. Funding, we are lucky that we've got at least another year and a half of funding available from monies the state had and has given to us. We've also been able to leverage both things that we learned, such as looking at our vaccination rate for middle schoolers going into high school. Here they have to have a tetanus shot before they can go into high school. Well, that's always been somewhat of a problem, but we've been able to leverage the fact that we're offering those vaccines and are currently going out to every middle school and offering vaccines. We're offering information on COVID, and we're able to kind of tie it under that from the state standpoint, but we're able to give those vaccines that they need going into middle school, those tetanus shots. But we're also talking about HPV and other vaccines that are appropriate for that age group, meningitis, that type of thing. So we expect this to help us grow some things over time. And that also comes from having a good partnership with the schools throughout the pandemic, that we were able to quickly set that up. So that's been great. As I said, legislation has been an issue. They took away monies that times they've threatened to just completely dissolve our health department here. Our health department is one of 6 local health departments in the state. All the rest of them are run by the state in all of the other counties. So that's been a concern. So we've had to play that legislative game, and we've had to make sure that we're doing things that we want to do, but we're doing some of them quietly in order to avoid the legislature, because they just continue to find ways to try and have an effect on us, I guess. I have concerns as this ends the public health emergency, that along with it, people are going to start to forget how important public health was. They're going to remember that we were important, but they're going to go back to, I'm afraid, the funding levels that we had in existence prior. Now, it won't happen quickly, but that's what's happened in the past, is that we get an event, we fund it well, and then slowly the funding decreases because it's not it isn't top of mind. We aren't good as Americans at doing preventative things, and that's even goes into the healthcare itself. We need to focus a lot on a lot of these social determinants of health, just safety, well-lit recreational areas, all of these types of things that are infrastructure based actually have more effect on the overall health of individuals than the healthcare that providers are providing in cases. So these are all important. Along with this, I'm concerned about individuals in our communities and populations thinking that, oh, the pandemic's over, I don't have to do anything anymore. It's not going to be a concern. I can't get it, or if I get it, it's not going to be dangerous. That's not what we're seeing. The other thing you're going to do is to stop doing all of the mitigation things. We still continue to push. If you're in an environment where you're unsure of your counterparts, you need to take appropriate precautions. You need to stay vaccinated. At this point, we started out, we've got over 70% fully vaccinated, but we very quickly drop off when you start looking at what percentage has got its first booster, drops down into the 50% range. And when you get to a bivalent booster, it's probably, last I looked, was in the teens, 4% that have gotten that. So, I I think that's another concern. I think that we will continue to give vaccines in our local clinics, but it is going to be a cost. And I've heard that the cost could be $100 to $125 per vaccine. I've heard that it will probably start sometime in the fall of this year, but no definitive answer yet on that. Testing will also increase, I'm sure. And as Dr. Ariola mentioned, those that are insured, whether through the exchange or otherwise, because it's considered a preventative health measure, they'll get their vaccines covered. The people I'm really concerned about are these marginalized individual groups that, once again, because they're underinsured, or not insured at all, are not going to get services that are preventative and have been shown to actually affect them at a higher rate with more dangerous subsequent problems than the other population. So that's going to be, an ongoing concern, just like some of the other medical conditions that we're seeing, in our populations. So all of those are concerns. As far as I think that everybody will be able to continue to give vaccines like they've been doing, unless the state law wasn't changed. So, instance, here pharmacists were allowed to give vaccine prior to the event. I think that obviously here they will continue to be available, but some states put in temporary measures for others to help vaccinate. That may drop off, and that would be concerning also. State level information. I think, unfortunately for us, our state, because of where we are and such, at one point, our state lost the individual that was the doctor that was over vaccinations in the state. And the reason was because she had put together a campaign to encourage teenagers to get their COVID vaccine. So the state, if we talk to the individual physicians there, I get the feeling that they're with us, but from the standpoint of being able to speak out, they are forbidden. They are not supposed to do that. So, they have to follow the state policy. And unfortunately, that's detrimental in the way it's set up at this point. As the health emergency ends, those are all concerns. At the same time, during this, we have had a lot of other things that have occurred. Mental health is a huge concern here, as it is across the nation. We're working on trying to build our mental health capacity. We know that we need to. We're in the process of doing a local behavioral health survey. This has been delayed 2 years. It was supposed to be started in the first part of COVID, but due to bidding and other things, government slowed it down, and it hasn't occurred, and just now is being undertaken. During COVID, we lost actually more lives in the last 2 years from opioid overdoses than we did from our COVID. We were very good and lucky with our COVID. When we got started, we gave vaccines as following the state. At the time that we were doing 55 and above, so those at high risk, when we looked at that near the end of that, before we moved to younger people, what we found is that of those able to be vaccinated, 80% of Hispanics that were able to be vaccinated at that point were vaccinated, and not boosted, just fully vaccinated. 53% of Blacks and 58% of whites were fully vaccinated. So we felt like we were doing a pretty good job at that point of getting to these, a lot of the communities. But that was only because we had great relations with our community partners that were trusted and were really working to get their populations seen and vaccinated, and understanding how that helped them move on, because most of these in those populations were our essential workers. We obviously saw high numbers and very early and throughout of illness in our essential workers. It's continued, but we did feel like, at least initially, we made good progress. That, unfortunately, as we've gotten to younger groups, has dropped off some. It's dropped off, period, for the groups, the age for as a whole, but it's also dropped off for our Hispanic and our Black communities. So I think that's a good summary of kind of where we're at and what we've done. I'm willing to ask and answer questions at this point.
Great transition. Thank you, Dr. Wright. Thank you, Dr. Ariola. So now is the time for us to dig in with these questions and answers. And my first question, Dr. Wright, you touched on it towards the end of your remarks, but how does the public health emergency impact children? We don't hear about children and youth a lot in mainstream media and with regards to the current guidance. So could both of you all speak to that in your respective geographic areas?
Well, in our area, our age under 18 group is one of our lower vaccination rate groups. Parents, even if they are willing to get the vaccine themselves, were unwilling to get their children. And no amount of education, short of one-on-one education with their personal physician, pediatrician, really has made much difference in that number. There was a small uptake of kind of early adapters, but after that, we kind of flattened out pretty quickly. And all the messaging we can do and everything else really hasn't changed that. It really has to be a one-on-one discussion. And the best people from the data I've seen are the pediatrician, family physicians that those individuals are seeing on a regular basis.
And so we did, so in Johnson County, Kansas at that time, we were doing pretty well with the different age groups until we started vaccinating those younger than 12, and then later those younger than 5. And I haven't checked the number recently, but to say that children are not impacted is far from the truth. It is true that older folks have higher risk of more serious consequences. And there's this thing called long COVID that we still don't know the long-term impact. I was reading this week of a young lady who, for the first time in over 2 years, was recovering her sense of taste back. And so we are talking in the public health community as we are looking to expand on public health research to look at how do we track those things and to better define them, to better understand them. But I think one of the reasons why in Kansas City region, Children National was Children Hospital was a pretty big player. Throughout our vaccination effort, they focused largely on vaccinating in our schools. And within a very short period of time, we vaccinated a lot of our school children because of those efforts. And to the extent that Governor Laura Kelly actually came down and acknowledged the work that Johnson County did with the schools. But then as the misinformation spread, and you really have to leave those things. In my county, I was presenting every Thursday to the Board of County Commissioners. I was giving them report every Tuesday, and I was doing that for a stretch, almost 7 months, doing Facebook Live every day because of the misinformation, just to counter those things. There are days when I did 6 to 7 media interviews, and that's not to talk about the written response, elected officials asking you to clarify. So public health workforce, that was a very traumatic period for those of us that did that. And we did those things at a huge cost to our health. Gil talked about mental health. And I would say there are some positives to the past 3 years. There are some positives to this public health emergency declaration. The spread of telehealth and the acceptance of telehealth is one such thing. The changes to law that's allowing others, pharmacies, for EMS to give shots, all of those steps that were very, very important to increase the resources that are available to vaccinate our residents. And now we're seeing some of the benefits. For example, here in Prince George's County, we have a telehealth service for physical, somatic, and behavioral health, 7 a.m. to 7 p.m. in our schools for students and for their families, and that's at a cost about $15 per student. And that's so important. And when you add that to the focus of the Biden administration on the 988, the National Suicide Crisis Hotline, that move to put money into 988 that's going across the country and impacting that crisis continuum of care, it's going to be in 10, 20 years time when we look back, it's going to be one of the more consequential public health decisions that we have made as a country, because we are now accepting mental health to be as important as physical health. And the help is there. Now we're short staffed. We don't have enough counselors or those things. That's very important. The other thing that I think this did for us is the use of community health workers. And so I am saying this, that is the future of public health. We saw that during the pandemic, where you really go out into the community, not just that's what we did in the pandemic. We go in there, we vaccinated people in their homes. We took care of transportation issues. We just did whatever it took to make sure that we protect our residents, even the most vulnerable. That's addressing equity. So when we have staff on the ground in the community, building trusting relationships, understanding what's going on, that is going to be what public health looks like in the future. And so, again, your questions about the children, the perceived or the theoretical, the risk doesn't seem to be a high, at least acutely in the short term for COVID. Long term, we don't really know. They're not quite as susceptible as those that are older, but I think we will be doing our children injustice if we say they can just be exposed and let them face the consequences later.
Great, thank you. I'm glad you mentioned the community health workers. In sort of thinking about the stat that you gave us, Dr. Ariel, about 50% of the workforce being reduced since the pandemic. I know that community health workers, formally and informally in some places, have helped, but I think you're right, strategically, that is something to consider across the country in the future. Okay, so let's talk about the workforce. I have so many questions. Let me just narrow down. One, I really want to, before we get to the workforce, we'll talk about that. I want to know what you are hearing from the state with regards to the public health emergency ending. How is the state communicating with your local agencies, or how are you receiving information? What's working and what are opportunities to improve? And I'm going to start with Dr. Wright.
Well, our state considers the emergency to basically have been ended about a year and a half ago. We on an individual basis talk with our state health directors and such, but the state really, about a year ago, when they took all the things away, they were done. I mean, we were still in the middle of just getting people vaccinated early, and our governor was here in the middle of downtown Nashville without a mask on, saying we're wide open, come on down, when we were trying to mitigate the numbers in bars and all of that. So the state really hasn't been doing anything with COVID to speak of directly, and they've had leftover funds, which in some cases they've offered to us, and we're happy to take those funds. But from that's been our experience here in this state.
And I think that the differences that we see in what I call political response to COVID across states and even across counties, it's really uh, it's really something that's a little bit I wasn't expecting to be to be that much. I would say that very similar to Tennessee in Kansas, we were pretty much down about a year ago, and really the landscape for me to undo some of those political decisions that were made is going to take years. The impact of the ability of public health to even do public health. Now, Maryland is very different. It is different, and we have regular communication with the state. There's no mandate to wear a mask, but if you walk around, quite a lot of people are wearing their mask. Is a state, at least the county here, that's very receptive to public health message. And talking with the health officer that retired in December, Dr. Carter, say really didn't get a lot of political pushback here. I wish I could say the same thing in Kansas. I couldn't. It's not a lot of threats to our jobs, threats to our lives, really on hidden, very overt racist comments every single Thursday that I had to endure there. So those are facts that are there. So my point is also when within the states, when you look at the local political structure and the makeup, I think those are very, very important, because it's amazing differences between what you're able to do in one county to the next. Again, depending on the makeup of the politics and who is on the board of county commissioners and who are making those decisions. So right here, Maryland, we are having very regular communications with the state, even as they are getting ready to resume pre-COVID eligibility process for Medicaid. We're having those conversations with them. We're providing feedback. We know that things are going to be rolled back, but in public health, we know that we have fought for years to have a lot of people enrolled in insurance and have access to preventive care. We don't want that to change because of this. I think the estimate for the number of persons in Maryland to lose their eligibility is about 400,000, I think, roughly. And so again, it's good to know that the part of the Biden administration's process is opening up the exchange, the marketplace from March 31st to July 31, so that those people that are likely to lose their eligibility can start shopping for coverage. So those conversations are happening, but again, consistently, what the health officer roundtable, that's what we call it here, is consistently sharing with the state is a focus on equity, and we don't want to lose the gains that we've had, and that's important. And I think that's one of the positives of the last 3 years, in addition to telehealth, in addition to better relationships with our community and better relationships with FQHCs and our health systems. We still have major gaps with data, but it's very, very important that we stay vigilant, and in spite of the political obstacles, public health has to continue to push.
Thank you, Dr. Ariola. So it's not lost on me that the public health workforce is the one that champions the public health message. Even way back when, before the pandemic, when it came to influenza vaccines, that was an uphill battle for us to encourage folks to get their flu shots. So we're trying to talk to regular lay individuals. We're also having to negotiate that same conversation and narrative with our elected officials. And we know that this is a tough time with politically with the landscape. Dr. Wright, how do we do that in Tennessee, and states where we do have a supermajority. How do we not lose hope, talk about true public health priorities that we know are tried and true, and navigate that political landscape?
Good question. I think that one of the first things I'd say is that we try and lead with data. I mean, throughout the pandemic, the one thing that we consistently said was, we're doing this because that's what the data says. That's what the data tells us, and so that's science. Unfortunately, in a lot of the red states, a lot of the southern states, we've got a lot of people that don't necessarily believe that science. But I think that we have to work with our partners, because we really have to go into those. I'm focused on the areas that are underserved. So, and that means that we've got to go into those areas with trusted partners who can help us with the messaging, help us with approaching those people. I think community health workers are going to be a huge help with that. We've just had ours for about a year or a little more. And so we're just getting them trained and ready to be really out on their own. But I think that they are the future of a lot of this, because they become trusted within their own community, and they're a conduit then to those individuals. I think we've got to continue to push for funding that gives us the ability to support these communities. And I think we can talk a lot with our state about, and state legislature and all of that, about here's where our vaccination rate is, not focusing on COVID, but we can focus on the things they understand. They understand tetanus. So we could talk about some of those types of things, but we just have to be careful that we don't hit some of their hot buttons. So it is a very political piece for us that comes into play on a daily basis in a lot of ways. But I still think it's having those close relationships with trusted people out in those communities that is going to make the biggest difference.
Great, thank you. Dr. Ariola, what would you like to see happen to be more comfortable with the ending of the public health emergency status?
So great question. I think what we need to do broadly in public health to address really virtually, in my opinion, every public health issue, whether it's COVID, whether it's gun youth violence, whether it's opioid addiction. I think it's very, very important to do 4 things, in my opinion. I think the first thing is what we've talked about the most, which is we have to build bridges into the community, better bridges. We have to nurture existing relationships, and we have to build new ones where we don't already have them. We have to build bridges into the African American community, into the Hispanic community. We can't wait until we have a pandemic to do that. I'll give an example in Kansas. When we worked with our Latino community, based on data, keep in mind that we had grants that are coming in, equity grants for COVID, that allowed us to do a lot of things to give community organizations resources. And so working with the Latinos through the church, the Catholic Church, and the politics even within the church was concerning, because we were going to vaccinate at the church, and then we got there and they got order from high above to not do it. And so, but again, because we worked through people that they trusted, we moved that vaccination last minute to the health department, and that day we still vaccinated almost 150 persons, meaning that they left that place and drove back down to the health department, which is about 10 miles, to get vaccinated. And so that building those relationships are very, 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 very important. And that's how we were able to bridge those gaps later in the vaccination process. I think the second thing is really what you are doing with this, which is to focus on equity. I think that's very, very important, to use data to show where the gaps are. Look, anytime you are looking at data at the 30,000 foot level, it doesn't tell you anything. Today I was looking at in our county, looking at obesity, but also looking at other chronic illnesses, looking at the number of endocrinologists here and looking at the number of dialysis center. And it gives me a perspective here. You have a lot more dialysis center here than you have endocrinologists. So basically, the preventive care, we don't have enough resources. By the time you are requiring dialysis, your kidneys already failed. And so you have to drill down into the data to get information that you can use to make informed decisions. And we cannot let detractors take us away from a focus on equity. In fact, it's tough to do public health if you don't focus on equity. I think the third thing is what we throw out there, what we call health in our policies. I think where we are, even these things we complain about, is a consequence of the policy decisions that we made 10, 20, 30 years ago. So if the future will be different, we have to have policies that protect and promote public health. And I think the fourth piece is really what Robert Wood Johnson Foundation put out there, which is building a culture of health. It's amazing how the upstream factors that impact chronic illnesses, that impact STI, that impact all of this that we talk about, all of them come together. If you're poor, your health is poor, you don't have access to insurance or preventive care. If you're poor, go and look at the community. You can literally, in every community in this country, map out socioeconomic status and overlay them with whatever diabetes, obesity, they all work together. You can look at investments in those communities, see how much we put into sidewalks, where you have food deserts. All of those things are typically in places or communities of color where we have underinvested in a long time. And so everywhere that I've been, I always tell them, show me your investment as a county in the last 10, 20, 30 years. I'll tell you where your poor health residents are. And so if we focus on those first things, irrespective of the politics, we can make change, especially around health in our policies, because the only language politicians know is their constituent advocating for things. And we've got to do better politicking in public health.
Right. That really resonates with me. There was a question earlier. There's so much going on in the chat. I think I saw something come through about asking about social determinants of health to change how we think about improving public health and healthcare, something to that level. But you just articulated it, the health and all policies piece. Dr. Wright, when talking about health and all policies, it can be difficult or challenging when you're talking to colleagues, leaders of other agencies, the mayor's office, for instance. How do you convey a public health principle knowledge in a way that sort of puts it where the goats can get it? Because those audiences are also helping to influence policy.
All right. So we've been working with health and health policies for over 10 years now, and recently more focused on it. But we have a number of counterparts for our health and health policies with representatives in a number of the metro departments. So that, and that's kind of during COVID kind of dropped off a little bit. We're reestablishing that, but having somebody that knows and has had some training from us sitting in a department helps them just continue to think about that. The other thing is, every time we talk about health, we try and give day-to-day examples of things that we know make a difference. We know that children with a lot of ACEs have poor outcomes. They're more likely to become addicted. They're, alcohol use, all of these different things. So if we can look at this from a health standpoint and we can change those and make them more resilient, long-term, we reduce our overall health care costs. The biggest problem is when you're talking with politicians, they're in term for 4 to 8 years. And most of these things take 10, 20, 30 years to really make the big difference. So you've got to really work hard to get them to buy in, and it takes a lot of education. And so I think you have to start early. We have in the past invited all of the new council members and new mayors to come visit the department, get to see what it is, and get an initial briefing on what we do, so that we at least start to develop relationships very early in their tenure, so that we can try and work with them. Here we happen to have animal control under the health department. Unfortunately, I get 10 questions about animal care and control to every question I get about people. But every time they bring up an animal, I have a chance then to say, yeah, but we're worried about the people too. Don't forget, we've got to take care of the owners of these animals you're worried about. So you've just got to figure out ways to continue to bring that back up and help them understand.
Great, thank you, Gil. Okay, we're going to go off script a little bit. There is an attendee. Her name is Betty, I believe Ezel, and she's been putting a lot of good things in the chat from a grassroots community perspective. Betty, if you're willing, I'm not putting you on the spot, and able, I would love for you to take just 1 minute and share from us perspectives from the grassroots community.
It would be my pleasure.
Okay, fantastic. And you may not want to be on camera because I know you weren't prepared, but you have the floor.
Okay, I can do camera as well. I did finish my lunch.
Okay. All right. It's up to you. You have the floor. Tell me what's working well in your community with regards to the public health emergency ending. Betty, are you still there? I don't know if you're double muted.
I'm here. You made me a panelist, which made me need to sign back in.
Oh, okay. Now can you talk?
Yes.
Okay. All right. Go ahead. You have the floor.
All right. Thank you guys so very much. I reside in Florida, and we are a small county. We're probably the third largest in terms of elder population. At one point, I was working with the CDC Foundation, and at the end of that grant, my leadership at the county level asked if I would stay on the phone because they wanted to talk to me about something, and they had HR on the line as well. And they asked if I would continue to do my program that I was doing through the CDC at the county level, if I would do it for the health department. And I said, yes, of course. So for me, the number one thing was to not just talk the game, but to walk it and live it. Because especially among our elder community, they know when you're lying. Not telling the truth, they know when you're lying. So as I would go out to the different churches that would have me, before I even started a conversation about the health department or COVID or vaccinations, I would say, I want to be sure that I'm sensitive to your church's doctrines. And so I would ask them to tell me a bit about their church, and if it was permissible, if I could step into their sanctuary so I could just feel it. And with that being said, relationships started to be built, and we were able to get 90% of the people, elder people in our county, vaccinated, which spilled down to grandchildren and children.
I'm wondering if you can just, in the last few, like maybe 15 seconds, 20 seconds or so, talk to us about the public health emergency, the impact on what you're doing in terms of, are you able to navigate regardless? Is it a barrier? What is your experience with that?
Okay, so I've got you. We have been alerted that the public health emergency would be ending. We started preparing maybe a year ago that as the grant funding would disappear, that we would actually incorporate vaccinations and the like into our routine operating procedures. So we bit the bullet. We did some fine tuning to operations. And so now we continue to do that. We go out to different groups and speak. And in turn, we're able to continue vaccinations because people do want it. They just need the truth of it so they can partake of it.
Thank you. And Betty, what county are you in? Do you live
I'm in
in?
Citrus County, Florida.
Okay. All right. Citrus County, Florida. That was one of the questions in the chat. Thank you. And what I'm realizing from your comments is that the public health emergency may be ending, but the positive behaviors that were created from the public health emergency and the pandemic are still going strong. So thank you for sharing that. Dr. Ariola, I'm wondering if you can speak to public health emergency and how it impacts vulnerable groups, and I'm using that term very broadly. We had a question in the chat about the Amish community, and also I'm wondering about the immigrant community. What are you hearing? What do you know? Who is talking about this and engaging with making sure that the focus is also on immigrant communities?
Right. So thank you. Excellent question. I think one of the lessons, and I think ultimately positive of the response, is that public health had to make a conscious effort to reach these communities. We've always known, even when dealing with communicable diseases, infectious diseases, that health does not know, a virus doesn't know what your immigration status is and whether you are Amish or Black or brown or white. And so we also know that collectively to protect our community, especially for vaccine treatable illnesses, does require us to vaccinate a certain proportion of the population. That was the original theory or around the hypothesis, I would say, around COVID vaccines, that if we vaccinate enough persons, who are throwing different numbers out there, didn't quite work out like that. And so, but some of the challenges that are pretty obvious is for immigrant community, for example, is because of immigration stuff. I think the last Trump administration, at some point, even in Nashville when we were there, we saw a drop in the number of immigrants coming to our clinic after certain steps because they were afraid that somebody's going to report them to immigration. And if you across the country, those things were happening with the sheriff and other facilities being commandeered to arrest people for immigration stuff. You go to court at that time, you could be in trouble for immigration purposes. That was happening in Nashville. So those history are pretty clear, and so people know that it's here. And even here with a very high percentage of immigrants, Spanish population here, it's a challenge moving forward. And so when I say we have to nurture existing relationships and build new bridges, that's really what I was referring to. We have to do all that we can. It's got to be a trusting relationship. And that's impacting not just our vaccination rate, that's impacting everything. In opiates, for example, around here, the overdoses that when these kids think they're taking something else that's laced with fentanyl, we are seeing a lot of those cases increase in the immigrant community here in our schools. And part of that is education. Part of that is understanding. So we have to do that. We have to have a diverse workforce that looks like the community that we serve. That's always been a big thing for us. It's not having a group of 10 community health workers and then you pull in one Black person or one minority person. That's not in a community that's 40-something% minority. That's not going to work. Unfortunately, the reality is that people are comfortable with people that understand their culture, speak like them, look like them, and we've got to get to a place where public health workforce really reflect what the communities need. And so whatever it takes for us to build those relationships. Again, the other piece that's important is not qualifying for insurance, medical insurance. I think Maryland really tried to do something in this last session. I think it kind of failed eventually, where immigrants would have qualified to buy insurance in the marketplace, regardless of their immigration status. And so for me, if people pay for that, why can't we do that? And so, I went to a school here in a part of the county we call Langley Park, was one of my first trips here. And these kids there who really struggle with speaking English, but the way that they structure the school, it's amazing the progress that these kids made over time. But one of the paintings they did there was no one should be considered illegal. And so I don't know how we can call human beings illegal, but we've got to get beyond that. That's the thing again in our country here. I've mentioned other OECD countries. I've talked about how their health status is much better, because there, if you struggle with being able to afford your housing, if you struggle with being able to pay for your food, if you struggle with any social or economic determinant of health, the mindset there is what happened to you? What can we do to help you? In our community, it's what's wrong with you. You're poor. You're poor because of your race. You're acting in such a way because of your race. And you look at these kids, because of the environment that they grow in. Look, we talk about youth violence. We talk about opioid addiction. I'll tell you what my perspective is. These children are a product of the environment that we allow them to grow up in. Our environment must be one that enables these children to thrive. It's not working for us. We're not doing a good job until we change those constructs and take responsibility for the product that we are seeing. These kids grew up under such trauma. And then when they grow up and they misbehave, we throw the books at them and send them to jail. So,
Dr. Ariola, yes, thank you. And I hate to interrupt you, but we're almost at time. And there are a couple other things that I wanted to cover. But you set us up really well. What I heard from you specifically was that it takes trust in the community in order to build solutions. And I also heard that from Dr. Wright, as he was talking about how he communicates with other local agency heads, and also with our elected officials. But with the Vaccine Equity Cooperative, that is a place that we've set up to have that safe virtual space where we can share information and people can draw information and take it back to their community solutions that work for them. So in 2021, we launched the Vaccine Equity Cooperative. We hoped that the collective response around equity challenges exposed by the pandemic would spark a health equity movement. Now, I'm not going to say it sparked a health equity movement because that movement was already there, but what I can say is that the pandemic amplified and actually showed a spotlight on the health equity movement that so many of us have been living in for so long. And all of this started with the COVID-19 vaccine. More than 2 years later, we are tired. We are sick and tired of being sick and tired. Many of us believe, but we're here and we're still committed to the fight. So our work began with a core group of organizations designed work to protect lives and expand vaccine access during the public health emergency, but also expanding equitable strategies for systems change, which we've been lifting up over the last couple of years that we've had our webinars. Many of you have been on this journey with us in working groups, on our webinars, in partnerships to address the dire and urgent health inequities that predate and were exacerbated by COVID-19. Over time, based on a national direction and the needs of the communities that many of you have shared with our work, we have evolved beyond COVID-19. And we're going to be focusing still not just on the Vaccine Equity Cooperative, but broadening the way that we think about and that we tap into a health equity response for different areas. Stay tuned. This is going to be a larger tent for education, for advocacy, for action, for power building, for all of us just to come together and continue the work that we've been championing for these last few years. So the post-webinar questionnaire is here for you to respond to on the webinar. So please respond to that. And I believe that, Danielle, I'm going to ask you if you can pull up the response to our other question, our other poll question about what is it about the priority? This is it. What is the one thing that you can focus on your sphere of influence? Education. And I think I want to see all of these responses. I think we might be able to get the link and share that out somehow with the proceedings for this meeting. But sharing of information, factual information is one thing that all of us can do with our immediate family members, our neighbors, hopefully coworkers, and definitely in the public health space. To learn about how you can get more involved with health leads or with the Vaccine Equity Cooperative, please go to, and I think my colleagues are posting the links in the chat if they haven't already, Vaccine Equity Cooperative's website and also healthleadsusa.org for our website. I believe that is it. Thank you, Dr. Ariola. Thank you, Dr. Wright, from my colleague with the Tennessee Department, the Metro Public Health Department, for sharing your insight and for giving us hope that we can get over this. You all have walked that walk during the pandemic and uncertainty, and I know we feel some uncertainty with how the public health emergency ending is going to roll out, but please come back to the Vaccine Equity Cooperative for information, and we'll be considering additional webinars for additional information as we learn more about the rollout. Thank you. Have a wonderful, wonderful afternoon, and we will see you a little bit later. Bye-bye.